We are continuing with the Ecmo series, and today's topic is on mechanical complications of Ecmo. So complications during Ecmo are rules and not an exception. Usually they arise unexpectedly and emergently. It is essential to diagnose and to treat the Ecmo complications promptly to have a safe and successful Ecmo. So these complications are broadly divided into equipment or circuit related or mechanical complications, which we will be seeing today, and the rest of the part is related to internal milieu of the patient, which is patient related complications that we'll be looking at subsequent lectures. Now coming to incidence, as per the ELSO statistics, the mechanical complications which are reported are maximum in neonatal respiratory ECMO, that is 82%, in pediatric respiratory 77%, in adult respiratory 60 to 65%. In cardiac ECMO, mechanical complications are reported in 60 to 65% more in neonates than adults. Amongst all the complications, clot remains the most common and major complication in both cardiac and respiratory ECMO, and it ranges from 27 to 53% with more preponderance for neonates than adults. Second most common complication in pediatric and adult population for both cardiac and respiratory ECMO is oxygenator failure, while in neonates it is cannula problem. So before going to the mechanical complications per se, we'll grossly have a look at all the circuit components of ECMO. So in this picture we can see a VA ECMO where the blood is drained from the venous side and then it goes to the bladder, which acts as a reservoir, then to the centrifugal pump, and then to the oxygenator, and then from there it is directed to the arterial side of the patient. So as you can see, there are many infusion ports, many connectors in between, which are prone to complications. So broadly in this table we can see all the mechanical complications which can happen. Most common is thrombosis. Clots may be in the oxygenator or in the bridge, bladder or hemofilter or dialyzer, or in other parts of the circuit like biopump or cannula. Second most common complication is air in the circuit. Air can be entrant either in the venous limb or the arterial limb, which can give rise to air embolism. Then is equipment failure, which includes power failure, pump failure, oxygenator and heat exchanger failure. Any part of the circuit can rupture like raceway or tube. There could be any cracks in the connector or cracks in the biopump. And lastly, the cannula related problems, like either problem at the insertion point itself or malposition of the cannula or accidental decannulation. So first coming to equipment related complications, all parts of the circuit have potential for malfunction. Hence it is essential to know how to recognize the malfunctioning and manage accordingly. The incidence of equipment failure ranges from 0.2 to 19%. Power failure is very rare due to loss of electrical supply, because all ECMO machines have battery backup and all hospitals have uninterrupted UPS backup. In case of complete failure of the backup, one should take the patient on manual hand cranking and should maintain the same RPM. And this complication is especially seen while transporting the patient on ECMO. Pump failure is again a rare complication. It is reported in less than 1% cases. It can be due to problem with either the external motor drive or centrifugal pump. Problem with the external motor drive can be problem with the electrical connection and can be managed by using another machine or using hand crank temporarily till the problem gets sorted out. Problem with the centrifugal pump will rarely cause the system to stop. The centrifugal pump problem can give rise to hemolysis and coagulopathy. Pump malfunctioning due to clot at the pump head or failure of one of the bearings gives rise to excessive heat production within the pump head, which again will lead to hemolysis. Pump malfunctioning should be suspected when there is sudden evidence of hemolysis or drop in the hemoglobin or rise in bilirubin. Even sudden high ACTs and APTTs without any evidence of any frank bleeding should raise suspicion of consumptive coagulopathy, and one of the causes of this is clot in the circuit. The obvious sign of malfunctioning pump is a visible clot in the pump head or sudden increase in the noise from the pump head. Treatment is to change the pump head at the earliest. Then coming to oxygenator failure, it is the second most common complication which is seen during cardiac and respiratory ECMO in adult and pediatric population, and is the third most common in neonatal ECMO. It ranges from 6% in neonates to 19% in adults. The incidence of failure is seen mostly with hollow fiber oxygenator, which is about 18.3%, then with silicon oxygenator, which is 6%, and is least almost 0% with polymethyl pentane oxygenators. Earliest sign of oxygenator failure is rising delta pressure. It is the difference between the pre and post oxygenator pressure. The pre-oxygenator pressure will increase, whereas the post-oxygenator pressure will decrease. Other signs of oxygenator failure are deterioration in lung exchange, gas exchange, which is indirectly suggested by rise in CO2 and decrease in the PO2 in the post-oxygenator blood gas, plasma leak, increased platelet consumption, and a picture of consumptive coagulopathy. Both the phases of membrane, that is blood phase and gas phase, can show some alteration in function in long run. The problem with the gas phase can either be membrane edema or atelectasis, while the problem with the blood phase can be embolism. Either of these problems will lead to VQ mismatch. So this table shows grossly all the problems which can be seen in the oxygenator. First is pulmonary edema. It can be diagnosed by condensation if it is present in the oxygenator, and post-oxygenator CO2 will increase. Cause of condensation is basically due to low sweep gas flow rate. Then if the problem is plasma leak, then yellow and foamy fluid will be seen at the exhaust end, and it is usually seen with hollow fiber oxygenator. If the problem is embolism, then again there will be decrease in the post-membrane PO2 levels, and it usually occurs because of clogging of the membrane with microthrombi. And if there is atelectasis, post-oxygenator CO2 will increase, and it usually results because of blockage of some pores of oxygenator. Next complication is heat exchanger failure. It is again a rare complication. In adult circuit, it is usually integrated with the oxygenator. It can lead to significant hypothermia, especially in neonates. Cause is basically thrombosis and occlusion of the blood flow, blood leak, and temperature probe cracking. It will give rise to visible clots, blood leak, and hypothermia in the patient. Circuit-related complications could either be clot in the circuit, air in the circuit, or rupture of any part of the circuit. So first, coming to thrombosis in the circuit, it is most common complication which is found during Ecmo run for both cardiac and respiratory support. The incidence ranges from 27 to 53%. Most common in neonatal Ecmo and more frequently in respiratory Ecmo rather than cardiac Ecmo. Clots are most commonly found in oxygenator. They are typically seen when the flow is slow or in stagnant areas. Major clots can lead to oxygenator failure, pump or heat exchanger failure, hemolysis, and consumptive coagulopathy. It can subsequently lead to embolism. High flows, adequate heparinization, heparin-coated circuit, a simple circuit with less connectors can prevent clot formation. If there are minor clots, then one can increase the heparinization and keep a close watch and look for any signs of consumptive coagulopathy or equipment failure. If there is evidence of any of these, one should be ready to change the circuit or a part of the circuit. Air in the circuit, incidence is about 1.8 to 4.9%, more commonly seen again in neonates. It can range from microbubbles to massive air embolism, leading to venous airlock. Causes of air in the circuit are air being sucked from the venous side of the circuit, a small crack in the circuit, open stopcock at the venous end, any dislodgement of the venous cannula, cavitation from excessive suction effect of centrifugal pump, and from the oxygenator when the gas phase pressure increases and it exceeds the blood phase pressure. Management of air in the circuit depends on location and quantity of air which is entrapped. Air on the venous side is relatively safe as it usually gets trapped in the bladder, biopump, or to some extent in the oxygenator. For small amount of air on the venous side, it can be removed by sequentially raising the venous line so that the air rises and then aspirating the air out of the circuit. Air on the arterial side, post-oxygenator, is however dangerous. Immediately, we'll need to stop the pump and try to remove the air move the air to the bridge by lifting the tubing to higher position. If the air is moving towards the patient, then place a clamp immediately on the line post-oxygenator. If the air enters the patient, then the head is lowered than the rest of the body as much as possible to move the air pockets away from the cerebral circulation. Higher doses of inotropes may be required if the air has entered the coronary circulation because it will cause acute cardiac decompensation. Once the causes of airlock has been identified, it should be corrected accordingly, and hyperbaric therapy, if available, should be considered. Tubing rupture. There can be a crack anywhere in the circuit, especially at the connectors or in the centrifugal pump or tube, or raceway rupture, especially with roller pump. The effect depends on whether the crack is on the venous side or the arterial side of the circuit. Treatment is to change that part of the circuit by double clamp method. Cannula related problems. There can be a problem related to design of the cannula, kinking of the cannula at the insertion site, cannula blockage or dislodgement or accidental decannulation. Kinking of the cannula mostly occurs at the insertion point and is mostly seen with non-spiral coated cannulas. Kinking at the venous end will lead to increased suction effect at the arterial end, and at the arterial end it will lead to increased resistance, which ultimately will give rise to hemolysis. Change of cannula is risky because it can give rise to precipitous bleeding and hemodynamic instability. Blockage of cannula or accidental decannulation is a dreaded complication. It can be even life-threatening at times. One has to immediately resuscitate the patient and give volume and reinsert the cannula at a different location to restart ECMO as early as possible. Thank you.